Thank you once again for having me, Nadia and Lazan. It's always a pleasure working with you too. For those of you who missed the previous two webinars, may I be so arrogant as to say you can get them on YouTube or somewhere like that if you'd like to have a look at them. However, tonight's talk goes around different causes of axial low back pain need different treatments. And I'm going to say this often through this presentation. There's no one treatment for low back pain, for axial low back pain. You know, as soon as somebody says, I have this thing, could be a technique, could be a machine, could be a device that solves, that treats everything. Know that it's a gimmick immediately, because nothing in medicine works 100% of the time for 100% of the people. So if you don't have a bit of a repertoire of things to do, it's a gimmick. No one thing treats everybody. So let's bear that in mind as we proceed along. As Nadia kindly said, I am from Jacaranda Hospital. I run my pain clinic there, and has been there for 13 years, Nadia, by the way. I'm older than you think. Okay, so Jacaranda Hospital. I try to say this about my pain clinic and to give some perspective on this talk too. The stated objective in my pain clinic, and if you come there, you might even see it on the wall, is that I treat pain. I don't smother it. I don't try to suppress it. I don't just try to bludgeon it down with more and more and more drugs. Anybody can do that. I like to believe that when I'm done with the patient, their pain must be, at the very least, under control. Or better, they should be pain-free, but by whatever means it takes, and on a little or a lot less or no pain medication. I am not. Now here, I practice pain, and I like to put myself there as a pain physician. And people in certain court circles call pain management doctors, not always incorrectly, as the prescribers. I'm not a prescriber. Please don't take this message as a message from a prescriber. And in fact, you might hear the word drugs or medication mentioned twice in this presentation. Please, this is not a presentation of how to add more drugs to the drugs the patient's already on. I just want to say this at this point, please. As you can see behind me, I'm doing this from home. I am a dog lover, and if I try to keep the dogs outside, they're going to make more noise trying to get into me. So they are around here. If they make a noise, and if they will comment, if they don't like what I'm saying, or if they think it should be said differently, that's their right. But please bear with them. I'll get them quiet as fast as I can. Thank you. So I'm not a prescriber. I treat pain. So a clear definition on the topic of this talk tonight is this is about axial low back pain. Not any other back pain, axial low back pain. First of all, before we can get into this talk, we must first make sure, and this is the problem with back pain, we must all make sure we're talking about the same thing or things. And so some definitions. First of all, we're going to talk about nociceptive pain, which is usually or not exclusively acute pain. And we're going to talk about neuropathic pain and two other things which I'm going to come to. First of all, let's just get clear in our minds, what is nociceptive pain? Well, all sensation, including acute pain. Now notice I didn't say all pain. I said all pain, acute pain, originates at receptors in the skin and tissue mostly. And in the skin and the tissues, we have these various receptors from these follicles and Merkel's diverticulum and the Pacinian corpuscle and Meissner's corpuscle. And these things sense touch, temperature, pressure, vibration, and so on. That's not what we're interested in. We're interested in these here, the free nerve endings. And these are responsible or sense touch, temperature, and pain. And these are the ones that we call the nociceptors. Now, this word comes from the Latin nocere, or I suppose that's Italian, nocere, I don't know what you want to say. It is to do harm. So to nocere, those who know the Latin, nocere, notum, or something like that, to do harm. So these are the receptors that sense when harm is being done to the body. And so nocere and receptor gives you nociceptors, which are the receptors that sense when there is harm taking place or potential harm to the patients. Now, there are three neurons involved in pain perception. You've got the pain receptors here. These are the free nerve endings. And they get conducted up to the spinal cord, dorsal horn, as fast fibers or the slow fibers. I don't know if you can see that because this seems to be a bit out of the way here. Okay. Unmyelinated C fibers. But then from the dorsal horn, so that's the primary neuron, just goes from the receptors to the dorsal horn. From there, a secondary neuron takes it up from the dorsal horn over to the other side of the spinal cord, anterolateral, up to the hypothalamus, where you get an emotional response to your pain. And then from there, it goes up to a tertiary neuron goes up to the cortex, and where you can become aware of the pain and you can localize the pain. So that's nociceptive pain, but everybody thinks that this is pain. No, this is acute pain. Chronic pain is different. Chronic pain is mostly, not always, I've got to say this, not always, and acute pain is usually, not always, this nociceptive kind of pain. You can get acute neuropathic pain, but it actually boils down to this kind of nociceptive pain anyway. But you get the third thing is neuropathic pain. This is usually or not exclusively chronic pain. Now, in the dorsal horn of the spinal cord, your sensory fibers all come in here, touch, temperature, pressure, vibration, and pain, and they make their first synapse here in the dorsal horn, and then touch, temperature, pressure, vibration cross over to the other side in the dorsal columns. But pain gets treated differently, goes to the anterolateral side, as we saw on the previous slide, and from here on up to the brain. The important thing here is that now for the sharp ones amongst you, you'll see that this slide is wrong. I only noticed it after I'd taken it from my source, the interneuron between the pain. It's not here presynaptically, it's postsynaptically there. So there's this little interneuron between the sensory fibers and touch, temperature, pressure, vibration, and the pain. And through this little sensory fiber here, the interneuron, activity in these fibers will decrease the amount of pain that you can sense, and this is called the pain gait. So when you hurt yourself, you bump your head, it's painful. Pain's going up there. But if you rub your head, it's nice and warm, touch, temperature, pressure, vibration, and through it stimulates this little interneuron and decreases the pain. Neuropathic pain is usually, notice this, is that a sensitized dorsal horn. In other words, the pain originates here. No nociceptors involved, nothing coming from the periphery. But the pain will still go up this fiber to the brain. The brain doesn't know, this is phantom pain. Chop off the nerve to the leg, and this thing starts firing off to the brain. The brain doesn't know, he lives in a small little dark room. He says, oh, this is the nerve that comes from the foot, so there must be pain in the foot. And the whole activity of neuropathic pain happens in the dorsal horn of the spinal cord. So that's mostly neuropathic pain. But now here's a very important thing, which we will see later on. Oh, and by the way, if anybody wants references to anything I say here tonight, please contact me. I'll send you the references. I'm not going to bore everybody by putting references up on every screen, but this is all in the literature. Any injury to a peripheral nerve, any injury, so it can be an amputation, or it can be just a neuropraxy, or any injury to any peripheral nerve, results in an immune reaction in the spinal cord dorsal horn. That immune reaction causes massive inflammation, which then sensitizes the spinal cord, and so these fibers can start firing up to the brain. So you cut off a guy's leg, you're cutting off and injuring a major nerve of a couple of origins and a couple of levels in the spinal cord. And so they all start firing here because of the immune reaction, and you have neuropathic pain. So that is definition, so we know what we're talking about later on, about nociceptive pain and neuropathic pain. Then I want to just point out that there's a difference between axial low back pain and just low back pain. Axial low back pain is pain coming from the axis of the spinal cord, of the spinal column. That's what we're talking about tonight. Somewhere else there's a slide that says just because a pain is behind a patient doesn't mean to say it's coming from his back, but we'll get to that later on. So now we all know what nociceptive pain is, neuropathic pain, and axial low back pain, right? But when we come to back pain, and this is the whole thing, diagnosis is everything. It's going to determine what you treat or how you treat it. So you've got to be able to make a diagnosis of different kinds of back pain. Not all back pain is not just back pain. There are different kinds and causes of back pain. So diagnosis is everything. Not all back pains are created equally. Just because pain is behind one does not mean it's caused by the spine. And there are numerous causes of pain behind a person that don't come from the spine. So already we're getting into different causes of back pain. We must see, when we see a patient, to determine what is this patient's problem before we start to treat. Because and I'll come to that later on. So one thing we must never lose sight of is that low back pain is a symptom. It's not a condition. It's not a pathology. It's a symptom of an underlying condition. And I don't know how to emphasize it enough, the diagnosis. It's like heart failure. It's not a diagnosis. Somebody says, what's this patient's diagnosis? Heart failure. That's only a half-baked thing. Because why? Heart failure due to is the complete diagnosis. Heart failure due to a valve lesion. Heart failure due to cardiac myopathy. Heart failure due to ischemic heart disease. That's the diagnosis. Same thing with low back. You can't say low back pain. What is it? What? Low back pain due to is your diagnosis. Give you an example here from now recently, in the 20th of November, 2 weeks ago. This article appears. Comparing pain, I don't know, it's gibberish, but comparing pain neuroscience education, followed by motor control exercises with group-based exercises for chronic low back pain. What chronic low back pain? Well, chronic low back pain due to what? This is not a diagnosis. So this actually, to me, this whole study is nonsensical, unless they, in their study, do the effort of explaining, specifying what chronic low back pain they're talking about. But I'll just pass over this thing, because if that is their diagnosis, it's nonsensical. It has to have a cause, like heart failure or a lot of other things. So, if low back pain is not a diagnosis, you, me, we must make the complete diagnosis. And honestly, we must look at this patient and say, this guy has back pain, and I think it's due to whatever. And you know what? I must make this diagnosis before I start treating him, so that I can know that my treatment will help this guy. I can't honestly make a diagnosis and make it fit into my treatment protocol, my treatment modality. Got to be honest and say, this guy has back pain for this reason, I must send him to so-and-so before you start treating him just because you can. How do you make this diagnosis? Well, back to basics. Things have changed since I was a medical student in the dark ages. Maybe they weren't so dark after all, but anyway, back to basics. We were taught, take a history from a patient, ask him questions about the pain, whatever. Then you examine the patient. And then from that, you'll start to get pattern recognition. You will say, this guy's pain does not fit into axial low back pain, the pattern of axial low back pain. This patient's pain is too far to the one side, or it's too high, or it's too low, or it's just not the right kind of pain. And then only then, you've done your history and examination and pattern recognition, will you then send the patient for a directed special investigation. Unfortunately, medicine has changed now. Patients walk into the doctor's room, they get sent for the X-ray or the MRI, and then we look at the MRI and we say, oh, this is normal. I suppose I better examine you, and then after that, I take a history. That's wrong. Back to basics, people. History examination, pattern recognition, and then a special investigation that confirms or refutes your diagnosis. But this requires a certain amount of honesty and ethics. Is this, after all I've done my history examination, pattern recognition, I'm starting to think this guy has axial back pain or not. I send him for, and I think his axial back pain is due to a tumor in his vertebrae due to metastases. Send him for an MRI and there's no metastases. What then? Am I going to treat him anyway as if he has metastases? No, I've got to be honest and say I was wrong, and I'm ethically bound to send him to somebody else. There are numerous causes of pain that occur behind a patient. Always bear in mind the pain in his back could be referred from some life-threatening conditions such as kidney stones, an abdominal aortic aneurysm. And I remember that before I became an anesthetist and I was seeing patients, we saw patients when I was a student whose main complaint was backache, low back pain, and the next thing they were on the floor because their abdominal aortic aneurysm had burst. Bear in mind there are other causes for back pain, referred pain from prostate problems or gallbladders or kidney stones, etc. And just the kidney, not just the kidney stones, the kidney itself will give you referred back pain. So that's a reason for pain behind the back of a person. Take a history. And then another important thing of pain behind a person, back pain, which just means it's behind the person. It's not from his spine. Impinged nerves. The most common nerves are the cluneal nerves, superior, middle, and inferior cluneal nerves, and the gluteal nerves, thereby the sciatic notch. These nerves become impinged on a regular basis, and they are very easy to do a neurolysis on and liberate these nerves. But patients get back surgery because nobody took a decent history. Or they spend 2 years, I'm not singling anybody out, they spend 2 years at the physio and the pain gets worse, but nobody will send the patient on to somebody else. Of course, sacroiliac joints is a problem, so is compartment syndrome, and of course, everybody's favorite, the overdiagnosed piriformis syndrome. Why do I say overdiagnosed? Because most of the piriformis syndromes are actually gluteal nerve impingement up here. Okay. And so, etc. There's lots of pain, reasons for pain behind a person. And they're going to all require a different therapy. You can't go and send the guy to the back clinic if he's got an abdominal aortic aneurysm. Doesn't make sense. You can't operate on the guy, do back surgery if he's got impinged nerve. You can't send him to the pain clinic and we do a radio frequency on him if he's got a psoas compartment syndrome. You've got to make the right diagnosis to get the right treatment. Right, so after all that, you finally arrive at the conclusion that your patient does, in fact, have axial low back pain. Pain coming from the axis of the spinal column. But it ain't over, because axial low back pain is also not a diagnosis. You've got the full diagnosis, axial low back pain due to. And that's what we're actually here to discuss tonight a little bit. This talk is not about, I'm not going into various treatments and putting one above the other and doing statistical stuff on that. I'm just saying that we have to make the correct diagnosis before we start treating. So as I said, axial low back pain is not a diagnosis. There are various causes of axial low back pain. Remember the difference? Lots of causes for pain behind the guy. One of them is axial low back pain, but then there's various causes of axial low back pain, all making a difference to the treatment. There is not one treatment for axial low back pain. There is not one. There are many treatments for axial low back pain because there are many causes of axial low back pain. Again, diagnosis is everything. I'll make an example. Those of you who saw previous webinars and know this slide now, it's like saying we've got cars on the road and the different kinds of cars, but we decide that because Ford is a car, well, all cars must be Fords, so we're going to treat all these cars like a Ford. We're going to take them to this garage, but we're going to service it and treat it and, do all the, follow the service plan of a Ford because, well, Ford is a car. Therefore, whatever we do to a Ford should apply to all the other cars too. And that's obviously nonsensical. But then why do we do it with other conditions like axial low back pain? Axial low back pain can be non-specific. But we can't decide that all axial low pain is non-specific and treat all the other back pains like a non-specific low back pain. Because there is a specific low back pain. And your low back pain could be could be specifically neuropathic or failed back surgery syndrome. You've got to make the diagnosis. You can't take all the, let's say you treat non-specific pain. You can't take all these and make them fit into the non-specific pain group so that you can treat them all the same. It's nonsense. You've got to treat each one separately. And this happens to a couple of conditions in medicine. Migraines, because the guy's got chronic headache, must have migraine, nonsense, lots of causes. And then after a while, migraine becomes the new word for chronic headache. Same thing with fibromyalgia. You've got a pain we can't explain, must be fibromyalgia. And then as previously discussed in the previous webinar, face pain. Not all face pain is trigeminal neuralgia, yet face pain has gotten the generic term of trigeminal neuralgia. That's only one type of face pain. Okay. There are many disciplines that treat low back pain. GPs, physiotherapists, various disciplines amongst the physiotherapists. They have different disciplines and types of treatment. And chiropractors, neurosurgeons treat low back pain, orthopedic surgeons, pain practitioners. And there are various kinds of pain practitioners. There are doctor pain practitioners, or there's some guy that's got a little machine gimmick he imported from overseas, and he opens business up on a corner and calls himself a pain practice. Keep your eyes open. They're all out there. It's actually laughable. Biokineticists treat low back pain. Acupuncturists, massage therapists, stretch therapists, Reiki, Pilates, yoga, and of course, everybody's favorite, the psychologists and various allied real psychology and phony psychology. Everybody's out there treating low back pain. You know what the truth is? They all work. They all work because they all have their place. But They all don't work. If they are applied to the wrong condition, to the wrong diagnosis, they will not work. And people can get very ugly, bolshy about their modality of treating pain, that this cures all pain. Then it's a gimmick, because nothing treats all the pain the same. There's not one of these treatments that can be applied to all types of back pain. They all have their place, and you must determine the place. It all depends on, what was the diagnosis? The treater, you and me, must know what we are treating before we start treating. And if we don't really know how to treat this thing, don't treat him. Send him on to somebody whose department or protocol or modality it fits into. Then we'll have greater success with our pain back management. Because, in practice, knowing what we are dealing with enables appropriate treatment, which then leads to more effective, successful treatment. Okay, so I've belabored that point enough. The most important thing, let's get back to axial low back pain. So how does your diagnosis start? There are two kinds, actually three kinds of axial low back pain. Non-specific and specific are the two main ones. There's a third one, which I've got an elephant there because it's the elephant in the room, and I will talk about the elephant later on. So, non-specific. Now remember, we're talking about axial low back pain, non-specific. It's a diagnosis of exclusion. Usually we can't find a cause for non-specific back pain. So we have to go and eliminate all the possible specific causes of back pain. We find none, the patient has then non-specific back pain. There's no precise structure identified with the causing of the pain. You can do x-rays, MRI, sonar, whatever you want to do. There's apparently, and I say apparently because I'll address this later on, there's apparently no precise structure identified causing the pain. So, it's also called lumbago, myofascial syndrome, muscle spasm, mechanical low back pain, and back sprain and back strain, because we actually don't know what it is. That's fair. We don't know what it is. It's non-specific. Then we'll treat it as non-specific. And the pain is mostly of a vague, remember at the beginning I said pattern recognition? And we've got this vague lumbar region pain. And it may radiate to the thighs, but not below the knee. Now, pain from the lower dermatomes of the spine, especially 4 and 5, must go below the knee. They must go down to the toes, in fact. So this is mostly a vague lumbar region pain with muscle spasm that may radiate to the thighs, not below the knee. Special investigations, even to the MRI, there's poor correlation to the condition. That's because X-rays and MRI, one must not forget this. X-rays and MRI show structure. They demonstrate the structure of a thing, whatever you're doing the X-ray of. And you can look on the X-ray, and this will come up later on again and say, there's nothing wrong with you. Look, your X-ray is normal. I think you're putting on with your pain because there's no cause of your pain. But the X-ray and the MRI are only showing structure. They say nothing about function. Just because the thing is structurally is normal doesn't mean it's working normally. And that is a very big mistake that is made with low back pain. X-rays and MRI only show structure. They do not show function. So they have a poor correlation with it. So there's no apparent Now, I'm saying apparent. I'm going to give you my opinion on this later on. There's no apparent structural pathology, as opposed to specific low back pain, which there is structural pathology. So maybe non-specific low back pain is neuropathic or functional. And it's functional problem. That's why we don't see it on the X-ray or MRI. So, non-specific back pain has got many treaters, and almost all of them work. One guy is a chiropractor, one guy to his GP, one guy to the physio, to try to. Everybody will eventually, hopefully, get him to feel better. I found 17 treatment guidelines in 17 various countries, but they all have 3 things in common. 1, low back pain. Actually, low back pain is common, and this is the back pain that they give all the statistics on. About 1 in 3 people will experience back pain in their life, and all these statistics you read, it's about non-specific back pain. And 5 or 10% of the people end up with chronic. We'll come to that now, chronic. And there's now number 17 guidelines all agree that a system is needed to separate specific from non-specific. We have to make that difference, because the treatment is heaven and earth. I mean, or heaven and hell, I suppose. That's how far they differ. And psychosocial factors impact outcomes. Sorry, the 4th one. And the treatments must focus on preventing this situation becoming chronic. This is the only place that I think, and this is my personal opinion and experience, it's the only place in chronic pain that psychosocial factors actually play a role. But here we go. Anybody interested? Great article, 2006. It's in a review article, and they reviewed something like 176 journal articles to come to their conclusions. Excellent conclusions. If somebody wants this, it will be in the recorded version, and I will give it to you too. Really an excellent article, 2006, not too old. Okay. So non-specific pain is divided into acute, and 80% of people who have it have a good prognosis within 4 weeks. Then there's subacute, and this is from 4 to 12 weeks. And if a patient is not better in 12 weeks, 3 months, we regard him as becoming chronic. Okay. 80% have a good response by 4 weeks. And by 12 weeks, 90% should have a good response, and only 10% go on to becoming chronic. What is the treatment recommended in these guidelines? In the acute stage, a patient can get by with self-care without any medical intervention. And what are most people told to do? Rest, bed rest, go lie down, it'll come right. That's not according to the guidelines of 17 countries. No bed rest. Patient must move. They've got to keep active. Of course, doing what they can do, not overdoing it, not hurting themselves, but as soon as they can get off the bed and do something, they should be doing it. And have a short course of physical intervention. So this will be chiropractic, physio, whatever, biokinetics, short course, 5 or 6 treatments. They should respond to that, not for 2 years. And they should do their own pain management, like ice and heat, stretching, relaxation techniques, which the interventionists mentioned above can teach them. Medical interventions, if necessary, should be analgesics. And notice, analgesics regularly. Do not give the patient pain medication as and when. The PRN should not be here. So you're going to take these tablets, you're going to take them every 6 hours. Sir, how do you treat your blood pressure? Only when the pressure's high. No, I drink it every day. Why? Well, I'll get it down. I've got to keep it down. Oh. And your cholesterol? No, I take my tablet every day. even if your cholesterol is normal. Oh yeah, I've got to keep it normal. Why don't we treat pain that way? So you're going to take your analgesics, you get your pain down, and you're going to keep it down. Don't let it get out of control every time. It takes a much bigger dose to get it back under control. Analgesics regularly. Seldom non-steroidal analgesics. This is in the acute phase, right? And almost never muscle relaxants. So the guy's not quite right after 4 weeks, and 4 to 12 weeks is your window of opportunity to prevent him becoming chronic. What do we need there? Now we need a bit of medical intervention. And the first thing the medical person must do, confirm that this pain is non-specific. Check the patient out again. Check if there's not a specific cause for the pain. Maybe something was missed the first time around when it was diagnosed as non-specific. Maybe there is something subtle, maybe not so subtle. Maybe somebody just missed it. But just confirm that it is non-specific. Do some psychosocial screening and do graded exercise regimes, behavioral therapy, and ergonomic interventions, you know, at work, proper chair, keyboard, screen, whatever, that sort of thing. If you're going to do medication, again, analgesics are the first line, non-steroidals and muscle relaxants. This order in which the drugs should be given, or one of the things that will make me think in the next coming up slide, show you now. So chronic, continue to search for a specific cause. Now you apply your multimodal, biopsychosocial modalities to try and help the patient. Now you try manipulations of various sorts, medications. Now they say maybe some non-steroidals, muscle relaxants, and analgesics. Now you're going for the big guns, the opioids, but not for long term. So this is why they sort of like third on the list, non-steroidals, muscle relaxants, opioids. They're your last resort, actually. Okay. So actual low back pain can be confusing, but you've got to just exclude specific causes and then treat him with your modality if your modality is for non-specific low back pain. If I may, I want to give you my opinion for what it's worth. After looking at this thing for daily for a couple of years, my opinion on the cause of non-specific low back pain. Remember, there's no apparent cause, and there's no structural cause, but there must be a cause. The muscles of the back don't all get together on a day and say, you know what? Well, we're bored. Let's all go into spasm today. Yeah, good idea. And so they're all going to spasm. There must be a cause. It's not just going to happen. There's got to be a cause for this. It's not nociceptive. Well, of course, we've discovered that there's no structural cause for this pain. It must be nociceptive. It must be neuropathic. Because the way the drugs are used too, analgesics, non-steroidal, if this thing was a structural cause, non-steroidals would work and muscle relaxants would work, but no, they say use analgesics first. We need to change our treatment of low back pain, non-specific low back pain, to a neuropathic type of treatment. And forget about nociceptive causes of non-specific low back pain. I don't think that's the cause. If there was, we'd find something on some sort of test. And because we can only test structure, what about the function? The nerves are not functioning properly, so you've got the pain. Anyway, my opinion. So we've done with non-specific. Now let's look at specific back pain. This is what you have to eliminate before you can call it non-specific. Here, there is a causal link to a structural pathology, as opposed to non-specific. And it is mostly nociceptive in nature. You can look on the X-rays and the MRIs, and you will see something wrong that is stimulating the nociceptors, and so it must be nociceptive pain. What do we have as possible cause? And the causes are legio, of course, could be anything, but things like injury, trauma, fractures, various fractures of the low back, vertebrae. Systemic diseases can give you low back pain. Interesting, one of the things is tick bite fever. If a patient comes with low back fever, low back pain with fever, eliminate tick bite fever. Any other infections, especially of the spine and the spinal area, can cause low back pain. Degenerative disc disease is a cause of low back pain. Could also have leg pain with it, but we're talking low back pain. Facet arthrosis. Come back to that one. Tumors, primary or metastases in the tailbone. Scoliosis. I could have a skew spine, which would cause his low back pain. Disc prolapses, spinal stenosis, but 5% of these people also have nerve root pain and leg pain. And so we see that there are lots of specific causes of low back pain. Diagnosis is everything. For example, facet arthrosis. Rhizotomies get done for any sort of pain or one of these pains, but it's only for facet arthrosis. If you're going to facet arthrosis, you do a rhizotomy. A rhizotomy has its place for sure. Rhizotomy, as the Africans call it. Only country in the world where it's called a rhizotomy. So you make a diagnosis. It doesn't help. You treat these people with a non-specific low back pain protocol. A bit of exercising, a bit of stretching. It's not going to help. He needs specific problem, specific treatment. Be honest. This guy, it doesn't fit into my protocol. I must send him off to somebody who can treat this specific problem. The converse is also true. You can't treat non-specific back pain with radiofrequency, rhizotomy, or surgery either. You can only treat them with these things if you know what the cause is. You don't treat non-specific pain with surgery or rhizotomy and hope the patient will feel better afterwards. Yeah. Right, so now we've discussed the differences, non-specific and specific, and how the treatments differ. And it's up to us to be honest whether this treatment required fits into our modality that we practice. But now, the elephant in the room. We have one in between these two. That is failed back surgery syndrome. Now, I want to specifically, I'm being specific, I want to specifically talk about failed back surgery without leg pain. With leg pain, almost a totally different animal, right? That means there's pressure on the spinal nerve or something. So I want to discuss here failed back surgery syndrome without leg pain. Pure back pain after spine surgery. Now, this could be nociceptive. It could be due to surgical complications. And I thought I had the list there. Sorry, I'll come back to that. And you can have neuropathic pain in spite of perfect surgery. And I'm not being funny when I say that, because sometimes the patients come there and they say, my surgeon says I can't have pain because the operation is perfect. Now, I'm not a surgeon, but I can see when a spine op has been done well. You put the X-ray up there and the surgery is perfect. But the patient still has pain. Because now part of the failed back surgery syndrome is neuropathic. I'll become clearer on this. The current concept is that axial back pain is always nociceptive. Leg pain is always neuropathic. That part I agree with. Leg pain is usually neuropathic. But times have changed from believing that low back axial pain is only nociceptive. There's an article out of the journal Neurosurgery. The title of the article was From Mechanical to Neuropathic Back Pain Concept in Failed Back Surgery Patients. A systemic review based on factors leading to the chronification of pain. Part C. Now they did a huge study where they compared different articles. This is 2015, not too long ago. And here's what they conclude here. Recent studies have revealed that acute back pain has a physiological nociceptive substrate. Acute pain, nociception. What I said earlier on, those nociceptives down there, up to the dorsal horn, nociceptive and acute pain. On the other hand, chronic back pain may be caused, and it has been now, that may has been taken out now. This is 2015. Chronic back pain may be caused by pathological plastic changes, not plastic like in mugs, neuroplastic changes in the neural system. So the neural system has undergone changes in chronic back pain. Hang on, that says chronic back pain is neuropathic. Not always. I mean, if you've got a surgical complication, you fix that. But if you've got this patient who's had this perfect surgery and there's absolutely no reason for him to have pain, and he has pain, it's probably neuropathic in nature. In other words, what's happened here? Central sensitization has taken place. That's what they mean by the plastic changes in the neural system, neuroplasty. So, again, we should talk about this now. This is axial low back pain without leg pain. Okay, that's a very long acronym, so try to be funny, I suppose. I'm not sure. So we have nociceptive and neuropathic. Now, it could be mixed. You could have the neuropathic element after perfect surgery or after complicated surgery. And the surgical complications, you can have fusion failure, non-union, you can have instrumentation failure, loose screws, broken rods, whatever, and of course, wrong level surgery. Not negligently, but the surgeon believes this is the level causing the pain, and afterwards the patient still has pain. You have to go back and do the other level. So some of them, the failed back surgeries, are nociceptive, obviously. But even these will have a neuropathic component. And if you don't have any of these and the surgery is perfect, it was probably purely neuropathic. This is a whole paradigm shift in thinking that failed back surgery syndrome can be neuropathic in nature and not always nociceptive pain. This is borne out, well, this is neuropathic pain is due to central sensitization. What causes the central sensitization? Well, nerve injury. And you know what? This is not bad surgery, but even if I cut my skin there, I'm cutting nerves. Any surgery, you're cutting nerves. Doesn't matter where you cut, there's nerves. And so back surgery goes through a lot of tissue to get down to the spine. Before they even get to the spine and the spinal cord and the spinal nerves, a lot of tissue has gone through there. And it's very sensitive tissue, and it's highly complex muscle arrangements there. And nerves get injured. Invisible nerves, they're very small. Often you take a patient who's had a bypass and you look in his leg where they extracted the veins. Touch there, he can't feel anything. Why not? They cut the nerves when they took out the veins. Remember, every peripheral nerve, I'm not sure if it makes a difference to the size of the peripheral nerve, but every peripheral nerve or the number of peripheral nerves that are injured cause an immune response in the dorsal horn with inflammation. So just the fact that you're cutting a guy can lead to chronic pain, resulting in central sensitization with a neuropathic element to this continuing pain post-op. There must be a reason for it. It doesn't happen by chance. And the cause, that's one of the causes, is just a nerve injury. Notice I didn't say the spinal nerve that was injured by the surgeon or something like that. It's just cutting of the nerves. And for various reasons, this pain then becomes this activation, the sensitization in the dorsal horn becomes permanent and persistent. And so you have neuropathic failed back surgery. What I have discovered, and I used to do a lot of spine surgery as an anesthesiologist, post-op pain. We know, it's well known in the pain literature. Everybody knows this, that one of the biggest causes of chronic pain is poorly managed and inappropriately managed acute pain. And in surgery, it's post-op pain. And if you don't strive to keep your patients pain-free after surgery, for at least for a couple of days, you will get central sensitization, and there's a very big chance that pain will become chronic. Then everybody throws their hands up and says, we don't know why your pain is chronic. Look, my operation is perfect, and it is. But your pain was not managed adequately and appropriately post-op. So now you end up with chronic pain. So we need to change our management of failed back surgery syndrome. Of course, reoperation is sometimes needed, but only to correct an obvious structural problem. The screws have come loose, the rods have broken. You know, whatever the cause that the patient needs, there's a hematoma forming, whatever. Whatever the cause is, it has to be fixed. Go fix it. But then later on, 6 months down the line, the patient comes in and says, I've still got pain. Look at the x-rays. Perfect. No nociceptive causes. What other conclusion can you come to? There's only two kinds of pain, nociceptive, neuropathic. If it's not nociceptive, it must be neuropathic. So even after perfectly structurally perfect surgery, we have to start managing our failed back surgery, that's axial low back pain without leg pain, more neuropathically than nociceptively. How do we do that? Well, not more surgery, unless it's absolutely indicated. Having another operation just because your back is sore after the previous one is not a good practice, because all it does is more nerve injury, making the central sensitization even worse, making the pain worse. And how many patients don't say, every time I had a back op, my pain got worse because of neuropathic pain. And even if the reoperation is indicated, as it often is, the pain will get worse afterwards because this correctly indicated surgery can cause more nerve injury and more sensitization. We must start treating the patients with failed back surgery at axial low back pain without leg pain. with neuropathic medication. And many of them, we won't go into them all now. You must apply techniques to reduce the inflammation in the dorsal horn. And the most, if we go into that, this inflammation is caused, mediated mostly, not exclusively, by interleukin-6. And the natural antidote or the natural blocker of interleukin-6 is butyric acid or butyrate made in the colon. Maybe we should got to reduce the inflammation in the dorsal horn. And then here's the thing. Last year in a court case, it was argued that this patient should not have gotten a spinal cord stimulator for his failed back surgery syndrome, because everybody knows that axial back pain is nociceptive, not neuropathic, so a spinal cord stimulator won't work. However, after implanting just on 500 spinal cord stimulators, it does work for low back pain, especially one certain brand of spinal cord stimulator. Does work very well for pure axial low back pain without leg pain. And I took to them a pile of articles like this saying, here's the proof that failed back surgery without leg pain responds very well to spinal cord stimulation. Now, spinal cord stimulation only works on neuropathic pain. So if the failed back surgery is responding to spinal cord stimulation, it's surely a bit of proof that the failed back surgery is neuropathic in nature. So after having said all this, I'm going to come back to diagnosis is everything. When you know what you are treating, you can treat it correctly and not blindly because this is all I know what to do. As in my pain clinic, patient comes in, I've got pain here, then I'll send him off to a surgeon. Send him off to the spine surgeon, send him off to the shoulder surgeon. It's out of my field. I can't help you by giving you more pills or doing a rhizotomy or something like that. Go away and go to the surgeon. And in my life, I've given the patient their money back and said, I can't help you. Here's your money. Go and see this guy. That's honesty, saying my modality can't help you. But I have to know what his problem is before I can say my modality won't help him. So at the risk of harping on it, but it's so important, diagnosis is everything here. The bottom line is that we started right at the top with this. Different causes of low back pain require different treatments. It's up to you and me to decide what is the cause of this patient's low back pain and get it treated or get it treated appropriately. Okay, that's me done. Raath out.
Thank you, Dr. Raath, for that mic drop. Very well done, as always. Yeah, thank you very much. We've got one question so far on the chat group where they're just asking, if you have lower back pain that feels like electrical volt at times, maybe 5 times a week randomly, and pain when you're sneezing, should you worry about that?
Yeah, I think that is close to what we're talking about, but not quite. That is now a low back problem, most probably with leg pain. In other words, there's a disc that is degenerating and is pressing on the spinal nerve, giving you pain down the leg. And when you sneeze and you increase the pressure, there you increase the bulge of the disc a little bit, pressure's more on the nerve, and you get your shooting pain. I'm assuming the person is saying shooting pain down the leg. That's why I was very clear that this talks only about axial pain without leg pain. But that kind of problem most probably needs to be, that's a specific kind of pain. You've got a disc lesion pressing on a nerve. No physio is going to fix that. No biokinetist, no swimming, no whatever. It's going to fix that. That needs, that disc, that pressure on the nerve needs to be, and I'm using absolute terms when I say there's occasions where, depending on the bulge, maybe physio will help. I'm talking general terms now. You don't treat a specific problem with a non-specific modality. So I think that's what that probably is. It was probably a disc pressure on the nerve made worse by sneezing. That's a very common thing that the neurosurgeons will tell you. A patient came in, he said, every time I sneeze, I get a pain shooting down my leg. Well, that's the reason. When you sneeze, you increase the pressure, the disc bulges some more, presses on the nerve, and you get the pain down the leg. So the two are related.
I think, Doctor, the best thing there is we should just not sneeze.
That's most probably, yeah. Or you know what? Sneeze more ladylike.
So I just want to ask anybody that's got any questions, you're welcome to put it in the question and answer section, or even the chat section. I'll give you a minute or so. I just once again want to say thank you so much to Dr. Raath. He has got so much knowledge and he's always prepared to share his knowledge. That's one of the things that Dr. Raath really, really impresses me. He doesn't want to keep anything for himself. And then Lizanne, once again, thank you so much for your assistance with the webinars. I just want to also remind everybody, just give Lizanne about a week. She will be sending you your CPD certificates after about a week, so don't stress. It's quite a lot of certificates to get going and send on mail. I think, and that's it. No other questions. Thank you very much. And have a good evening, and hopefully have a good last few weeks of the year. Okay, bye-bye.
Thank you.
Goodbye.
I'm going to...
Oh, wait, there is one more question, Doc.
Oh, yeah?
Just came in. I have fibroid and IBS. My doctor both causes my lower back pain, but the pain doesn't go away with meds he prescribed.
I don't know where this person is, but I can only suggest and ask you to come and see me, because your problem is definitely, if it's been caused by your gut, it's because your gut, I don't want to give this is another talk for next year maybe, your microbiome in your colon is not producing, first of all, butyrate that does all these good things is produced in your colon by your microbiome acting on certain fibers. And if that's all mixed up, you've got the wrong microbiome and the wrong fiber, and there's reasons for that, you will not be producing butyrate. So you can give all the drugs you like. You need the butyrate to block the interleukin-6. And if you don't block interleukin-6, no drug's really going to help you. So what you need, whoever you are, is to sort your colon out. It's a very, very, very common problem. And it's also the cause of fibromyalgia. Fibromyalgia can be cured. And maybe next week, if the people want, I'll give you a talk on how to cure fibromyalgia. But it is quite curable, and it's not a psychological or psychiatric condition. It's a gut condition, other end of the body. But anyway, that's I can believe that your back pain has been caused by your gut, but nobody knows how to fix your gut. You need to get it fixed. You can contact me if you need help or understanding how to do that.
I think that's maybe a very good idea. If you guys want to have a talk on anything specific, obviously pain related, please send us a mail at admin@Rhizoderm. That's where you got the invite from. And then we can address that maybe next year. Give us some topics.
Listen,
Okay.
yeah, it doesn't have to be pain related. I can talk on other things too, like motorcycle maintenance, tuning a V8. No, I'm kidding. Pain related, yeah.
Okay. Well, I think that's it for tonight. Thank you very much, everybody, and have a good evening and sleep tight.
Thank you.
Bye-bye. Okay, bye-bye.